My name is Christina Kramer. I am a board-certified obstetrician and gynecologist. I've been practicing here at CRMC for the past 4 years. I am a native Minnesotan, and then I went out east to complete my training and then moved back home to start work here. One of the conditions that's near and dear to my heart is a condition called pre-eclampsia, and that's on the high blood pressure disorder spectrum during pregnancy. And the whole scope of all the high blood pressure disorders in pregnancy is maybe too long of a conversation for this video, but pre-eclampsia is basically high blood pressure with protein in the urine in a woman who is pregnant, typically after the middle point of pregnancy after 20 weeks. Now there's other kind of variants of that. Women can have high blood pressure coming into pregnancy that then has pre-eclampsia superimposed on top. But in general, the majority of women will be diagnosed near term with new onset high blood pressure and protein in the urine. Now, why do we care about it? What I tell my patients is if it was just high blood pressure and a woman didn't have symptoms, we may not be that concerned. But the issue is some women will develop preeclampsia with severe features, and that's sometimes difficult to predict who those patients might be. Severe features can include patient symptoms such as a really bad headache that won't go away, visual disturbances, trouble breathing, severe abdominal pain. It can also cause lab abnormalities because it can hurt the kidneys, it can cause liver failure, it can cause compromised blood flow to the uterus, it can lead to small babies, fetal distress. In really severe cases, it can lead to what we call eclampsia, which is the addition of seizures in addition to high blood pressure. And that can be really dangerous for both the mom and baby. Now, fortunately, in modern obstetrics, eclamptic seizures are a rare thing because high blood pressure is diagnosed and treated more aggressively. But unfortunately, it can still happen in patients who maybe have not sought regular prenatal care or have additional clinical risk factors. Now, if it's at term, typically when a patient is diagnosed with preeclampsia, the recommendation for treatment is delivery after 37 weeks of gestation. Now, if a patient is preterm, things can get a little bit more complicated because we don't want to deliver a baby early unless we really have to. And that's where we would work in conjunction with high-risk pregnancy specialists, get their input, and then have a patient follow up more frequently. Typically, we would still manage a patient until 37 weeks unless she were to develop those severe features that I mentioned earlier, or if her blood pressures became difficult to control. And those are details that your provider would be going through with you at every visit. Patients are typically seeing us more often for more intensive monitoring to make sure that mom and baby are both doing well. Overall, it sounds like a really scary topic to talk about. Fortunately, it's not extremely common, and that all of the providers here are well versed in how to readily diagnose and treat preeclampsia. And we'd be happy to visit with any mothers who had concerns about additional risk factors for that condition during her pregnancy. Typically, for a patient to be diagnosed with an early pregnancy, she can just come in and do a pregnancy test here in our office. Or if there's any concerns about being a high-risk pregnancy, we're happy to see those patients in the office as well. We're also happy to see patients for what's called a preconception counseling visit. If they're worried about some medical issues that they may have, we can see those patients in the office and talk about what impact on pregnancy that may have even before they become pregnant.